guys know. And that's all for for the two learning outcome. The next one will be presented by Auni.
Okay, for the pathophysiology of the patient symptom, the first one is osteopenia. Right. Okay, osteopenia is a shortness of breath when lying down. So the patient
It's
is
orthopnea.
Otopnia. Okay, so the patient, he sleep with 3 pillows to feel better. So 3 pillow orthopnia is a very severe orthopnia. Okay, so for lying down, the pathophysiology is all compartments will lie in the same horizontal plane. So there will be like equal gravitational force. So blood will distribute evenly throughout the body. So because of heart failure, the pathophysiology of orthopnea, heart cannot pump out the blood returning from lungs when we lie down. So blood will pool in the blood vessel of the lungs and increase the pressure there. So there will be backflow of blood and fluid leak into the lungs, which called pulmonary edema. So low normal oxygen movement through the lungs. So that will cause the shortness of breath. Okay, so for the second symptom is pitting leg edema on both lower limbs. So first, from heart failure, the heart unable to pump blood efficiently around the body. So first one, the blood will pull off the heart, so it will increase the venous pressure and backflow of blood will happen. So fluid leak into the interstitial space and build up in the surrounding tissue. So it causes
What do you mean by blood pooling in front of the heart?
in the vessels.
Hmm? Can you explain in your own words?
Because the heart is unable to pump the blood efficiently around the body. So the blood over there, it will not go out. It will like backflow.
Anyone? I mean, it's supposed to be a discussion. Anyone can explain this in something that you all can understand? Anyone? Did you all do a discussion before coming for the second session? Yes? No? No answers?
No,
How?
doctor, we didn't do.
You didn't do. Okay, so is there anyone who can explain this? Anyone? Okay, who understand leg edema in the explanation here? Because I'm just going to go through. I mean, if you read this, you say blood pooling in front of heart. What does it mean in front of heart?
If I were to understand, it is in the mediastinum if it's not in the heart. I don't understand what is blood pooling in front of the heart actually.
Doctor, is it not the blood vessel supplying the heart?
All right. Sorry. I don't know what's wrong with my laptop. Can you all hear me now?
Yes, doctor.
Okay.
Yes.
All right. Okay. So can
We cannot hear you anymore.
Okay, can somebody just explain in a simple explanation? Okay, because that's what you do in PBL, not reading the notes. I mean, you can refer to the points, but if you try to explain it in a way that you understand, it will be much faster and more effective. Okay, so you want to give it a try again? Who was presenting just now?
Me. Auni.
Okay, Auni. Aini, use your own words.
Um, okay. So for pitting like edema, because there is a heart failure, so the heart cannot pump the blood efficiently, so there will be backflow of blood, and then it will de- because of the decreased cardiac output, so it will impair our renal perfusion and activate the RAS and increase sodium and water retention. So that's why there will be increase of fluid leaking and there will be edema in the leg.
Betul ke?
Doctor, can I help?
Sure. You don't have to ask my permission.
Okay, from what I know about edema is when your heart fails to pump, so there will be backflow of blood. So when there's backflow of blood, it goes back to your veins, right? So there will be increase of pressure in the vein. When that happens, there will be increase in hydrostatic pressure. So fluid will go out from the blood vessel into the interstitial space. So then fluid will build up, then it will cause edema.
Okay, thank you very much, Rania. Auni, faham? Do you understand? This is a totally different when you understand the case versus when you copy paste. You know, as simple as when you say backflow, you should know when you say backflow, it backflow to where? Okay, so Rania clearly stated that backflow, then it will accumulate in the venous. You know, so those are the things that show you understand or you don't understand. Backflow ke mana? So you have to refer back to the flow of the blood inside the heart. So if it's backflow, it will go where? And okay, the concept of because you are not in year 1, you are in year 2. What is the concept edema? What is the stalling forces? That is an important concept. Kan, I think we actually go through this many times also when you were in year 1. What is edema? And how do you explain the fluid going in and out of the vessels? Do you all know that?
Yes, doctor.
So that's how you should explain that. Okay. Then what about the renin-angiotensin system? The one that Auni explained is in the notes there. Auni.
Yeah.
Auni. Okay. What about the renin-angiotensin system? Can you explain? Can you explain that?
Okay, because of the
mm,
yeah,
because of the
because of the heart failure, so the heart unable to pump the blood around the body, so there will be decreased cardiac output.
okay, and then
And then the renal perfusion does not function normally, so it will activate the RAS.
okay,
Because it activate the RAS because to increase our blood volume because previously
okay,
it's not normal. Okay, then it will increase the sodium and water retention.
mm-hmm.
So it will increase the hydrostatic pressure. Increase the hydrostatic pressure, and then the fluid will leak into the interstitial space, which then cause edema. Doctor.
Okay. Can you all hear me? So it looks like. Can you all hear me?
Yes, doctor, we can
Yeah.
hear you.
So
Yes,
it looks like there are actually two mechanisms there you're putting, right? Satu is the backflow, which increase in hydrostatic pressure. Okay, which makes the fluid go out from the vessels, and another one with decrease in cardiac output, the increase in renin-angiotensin system, okay, which further increase the hydrostatic pressure. Okay, but okay, but as you explained, this activation of renin-angiotensin system is actually to normalize whatever that was low, correct? Betul tak? So by right,
betul.
it's
They will eat
actually
the
if it's only due to the increase in renin-angiotensin system, you probably wouldn't have that much of increase in hydrostatic pressure because it's just to normalize the hydrostatic pressure which was low before, isn't it? I mean,
yes,
if
doctor.
okay, can you
Um, I lost you. Hello, doctor.
Doktor disconnected kan?
Oh, you good?
Dah call balik dah.
Korang ada laptop tak? Sebab saya tak boleh share screen dah.
I guna phone lah. Tak, I guna phone lah. Tak, I guna laptop I. Hello, you all dengar tak saya?
Dengar doktor?
Dengar.
Wi-Fi, landline. Sorry, saya tukar phone. Tadi saya guna laptop. I think my laptop got problem. Aduh. Okay. Okay, continue. PLO 8. PLO 8. Alamak.
Ini banyak mesti masalah. Ini pun ni. 8
Hello. Hang on.
Okay, doctor.
Kejap je. Ni macam hang.
Hello, can you all hear me?
Yes, doctor.
Dengar?
Dengar?
Okay. You okay, you continue. Continue. I'll be listening from here. So you all just continue. I tak dengar.
Okay, so for this dyspnea, shortness of breath, because of heart failure, so it will decrease the cardiac output like previously. And when decrease cardiac output, there will be less oxygen. perfusion. So they will increase the ventilation. So the patient will try to breathe more air and cause shortness of breath.
Betul ke sebab tu?
I think that's one of the reasons.
Okay, what other reasons?
Maybe because he has like pulmonary edema and like
Hmm.
pleural effusion, so it's hard
Yes.
for him to breathe.
Okay. You explained earlier about pulmonary edema, right? What is pulmonary edema? When fluid accumulate in the... Sebab
Interstitial space.
tadi, because just now you explained orthopnea. Orthopnea, dyspnea
Um,
is
I'm
probably
going to
from...
ex- I'm going to
Hmm.
explain the pulmonary edema and pleural effusion in the next learning issue.
Okay. All right. Isn't that the same cause? Pulmonary edema and dyspnea?
Yes.
Yes.
Okay. All right. Dia macam ni lah. When I do my PBL, actually, we don't usually repeat the same thing over and over again. So that's why I like to do it as like macam discussion sahaja. Okay. If you were to go through your your learning issue one by one, it will take time. So maksudnya you have pathophysiology and sign and symptoms, and you have another topic of pulmonary edema. Correct? Is that how it is done?
Yeah, doctor.
Okay, so when you have a chance to discuss whatever, which one lah, pulmonary edema ke dyspnea ke, in one of the topics, you can straight away discuss that so that we don't have to again go through pulmonary edema. Like now you have dyspnea. In fact, earlier you have orthopnea. It's about the same mechanism. So just by one understanding of how things happen, it actually covers everything already. So when I do my second PBL, that's usually how I do it, so that we can skip some of the learning issues. It's not about presenting it to me. It's about discussion among you all sahaja, you know. Okay, never mind. Continue sebab saya actually susah lah nak conduct benda ni online. Alright, so you continue with what you are doing, because now I think when you discuss dyspnea, this is when you also discuss your pulmonary edema, because that's how you explain the pathophysiology, right?
Yes, doctor.
Okay, continue sebab saya punya line pun tak berapa nak elok lah.
Okay,
Continue,
so
and
now,
please use your own words supaya cepat sikit. Don't have to read the whole thing.
okay, so now I'll be talking about tension pneumothorax versus pneumothorax. So in general, pneumothorax is basically the air entering the the pleural space and accumulate there. So the difference between tension and pneumothorax is that tension, basically the air stays in the pleural space and compress the lungs, while in normal pneumothorax, or also known as open pneumothorax, the air goes in the pleural and still exits, but it will cause your lungs to collapse because the air did not go to your lungs. Instead, it goes to the pleural space. For the symptoms and causes, most of them are the same, but for tension, it's basically like the next step of pneumothorax. So for symptoms, it's hypotension, severe dyspnea, tachycardia, dry coughing, sudden onset of sharp chest pain, subcutaneous emphysema. So for causes, most of the time it's because of penetrating trauma or like stab wounds, and things like that. It can also be medical procedure induced, like lung biopsy, etc. Uh, and the risk factors are usually smoking or family history of pneumothorax, or intention is previous untreated pneumothorax. So below there you can see the picture. Like I said earlier, open pneumothorax, the air goes to your pleural spaces during inspiration, but when you exhale, it still goes out, but it just doesn't go to the lung, so your lung will collapse. While in tension, the air goes in the pleural space, then it stays there. So it gives this compression to your lungs. That's all for my part.
So I'm going to explain about the pleural effusion and pulmonary edema. So both are accumulation of fluid, it's just at different places. So I'm going to explain pleural effusion first. So pleural effusion is the accumulation of excess fluid outside the lungs. So there are a lot of causes, but since we're learning heart, so I'm just going to focus more on heart failure, but I'm also going to explain more about the other pathophysiology. So like just now, when you have heart failure, so there will be backflow of blood into your veins, right? So when that happens, there will be increased hydrostatic pressure. So the blood will flow out, and there will be increase in interstitial fluid in the pleura. Same goes to hypoproteinemia, but it's just there will be decrease in oncotic pressure, so the blood won't go into the blood vessel bag, so they will accumulate in the interstitial space, so which later will cause pleural effusion. But as for exudate type of pleural effusion, when you have vascular damage or infection, your antibody needs to go there, right? So they will increase the capillary permeability. So when that happens, fluid can easily go out into the interstitial space, thus causing increased interstitial fluid, which later will cause you pleural edema. The symptoms, like normal, non-productive cough, which means there's no mucus. You also have shortness of breath because your lungs can't perform well, and you also have chest pain. And the risk factor usually for those for anything that could cause vascular damage, like smoker, alcohol abuse, or you have pre-existing lung damage. And as for the pulmonary edema, instead of outside the lungs, it's excess fluid in the lungs. So same, the causes are practically the same. There's heart failure, hypertension. So how does that happen? Like just now, it's just a heart failure, and then blood won't be pumped efficiently. It goes back to the vein, increase venous pressure, and then fluid push into the airspace of the lung. It's just the same, but the differences is whether it accumulates in the pleura or it accumulates in the lungs. And then the symptoms also about the same. The risk factor is also about the same. Like I said, it's just the difference is the site where it accumulates. So next is aortic aneurysm. Aortic aneurysm is the enlargement of aorta, since it's aortic aneurysm, but it can happen to any vessels. So what causes it to happen is hypertension, arteriosclerosis, trauma, hereditary, anything that would cause your vessels to be damaged. So when your vessels integrity is compromised because of hypertension or arteriosclerosis or trauma, there will be alterations of your tunica media. So when that happens, since your tunica media is the thickest of your in your artery, so it plays the major role. So when there's weakening of the vessel wall, so when there's high blood pressure in the body, it will push the blood force will push the wall, which later will create like a pouch at the vessel wall. So when the blood pressure is higher, the vessel pouch might burst and will cause other symptoms. So there's a lot of risk factors. Mostly whatever that will cause your vascular to be damaged would be the risk factor for aortic aneurysm. So yeah, that's all.
Okay. So next, we will be talking about heart rate, cardiac output, and also stroke volume. So inside here, I'll be explaining about what cardiac output is, what stroke volume is, and what heart rate is, and also the regulatory mechanism. So for cardiac output, we know that cardiac output is basically the amount of blood that is being pumped out by each ventricle per unit time. And as we all know, cardiac output equals to SV times heart rate, stroke volume times heart rate. So how is the regulation of cardiac output is by regulating the stroke volume and also the heart rate. So for the um, stroke volume is basically the amount of blood that is being pumped out of each ventricle per beat. And stroke volume is affected by end diastolic volume and end systolic volume. So for end diastolic volume, it is the volume of the blood in the right or the left ventricle at diastole. And EDV, it depends on three factors, which is the filling pressure, the filling time, and also ventricular compliance. So for the filling pressure, um, for filling pressure, ventricular filling pressure, it will depends on the arterial filling pressure. So when there is increase in arterial filling pressure, it will delay the venous return to the heart. Therefore, it will lower down the end diastolic volume. And anyway, we will see the regulation. There's a not a table, a mind map down there. So we will see it after this lah. So for filling time, we can see when there is high heart rate, there will be a shortened diastole, and that will lead to low EDV also. And for the ventricular compliance, when there is high ventricular compliance, so at a given filling pressure, they will produce a greater increase in ventricular volume, which then will lead to a high EDV. So for end systolic volume, which is the volume of the blood in the ventricle at the end of contraction, it depends on four things: preload, contractility, afterload, and also heart rate. So preload is the volume of the blood in the ventricle of the heart after the filling and atrial contraction, meaning after atrial contraction and then it goes into the ventricle. So the volume in the ventricle, that is the preload. And second one is contractility. Contractility is basically the strength of the heart contraction at any preload, and it is related to the levels of calcium in the cardiac muscle cells. And next, it depends on afterload. Afterload is the pressure in the artery that has to be overcome by the semilunar valve in order for it to be opened and the blood can flow out to the out of the heart. And also, it depends on heart rate. So down there we could see can you go down at the table? Bukan table tapi. Okay, yeah, that one. So here we see the factors affecting the stroke volume. So when there is increased preload that I have mentioned earlier, it will increase the stroke volume. Same goes to increased contractility. It will also increase the stroke volume, and also decreased afterload will increase the stroke volume. So then after we know about the stroke volume, then it can affect the cardiac output. So after stroke volume, we'll see on heart rate. So heart rate is the frequency of cardiac cycle, and it depends on a few regulations also, which is the first one is the autonomic regulation. So in the autonomic regulation, you will get input from sensory receptors and also higher brain centers, and it will go to the cardiovascular center in the medulla, and it will either increase or decrease the frequency of nerve impulse through sympathetic and parasympathetic branches. And then, as we know, in the heart, there is not two types, there is two different. Okay, whatever. The first one is the pacemaker. What I'm trying to say is the pacemaker is affected by parasympathetic and sympathetic, but the myocardium is only affected by sympathetic activation, innervation. Yeah. And then after autonomic regulation, the heart rate is also regulated by chemical regulations. Chemical regulations, I think everyone knows we have epinephrine, when there is epinephrine, high epinephrine, there will be high heart rate. Like calcium levels in the myocardial cells also will affect the heart rate because it will cause more contraction. And besides that, you have other factors, which is like age, gender, and physical fitness. So as you can see, the blue one, the nervous system, when there is increased sympathetic stimulation and decreased parasympathetic stimulation, it will increase the heart rate. So we have chemicals, it will also increase the heart rates, depends on the levels of the hormones and also the chemicals in the body. And also the other factors can also increase the heart rate. And the last diagram there shows the path of the regulation that I said earlier. So it goes from the cardiovascular center to the it goes from the higher brain centers and sensory receptors, and it's being passed to the CVS center in the medulla, and it goes affecting the heart rate by either sympathetic or parasympathetic. So it will either increase and decrease the heart rate. So these two will affect the cardiac output. So that is how everything is being regulated. Yeah, that's all for the regulation.
Hello, who's presenting JVP?
I think it's Faida. Is Faida in?
Hello? Hello?
Yes,
Hi, we can hear you.
Yes, Faida, we can hear you. Continue.
Okay, the JVP, I'm not going to read it because there's no time. So the explanation, basically it's like, it is used to observe the pressure of the venous system, or like the central venous pressure. How do we check it? Like in CST methods, but then the patient is asked to lie on like 45 degrees, and then you have to turn your head, and there's like a pulsating, I don't know how to explain that. There's like something in the neck that is the JVP, and so a ruler is placed close to it, and then a ruler is also placed on the sternum. So both rulers meet, and then that particular point is where is the measure for your JVP. So like the explanation said, it's an indirect measure of the central venous pressure because the internal jugular vein is drained directly into the right atrium via the superior vena cava. Did I explain properly how to check it, or should I explain that again?
you can explain very briefly.
Again, okay. So the patient is asked to lie on the bed, but then it's slightly raised up to 45 degrees, and then the neck is turned to the side. There is like you identify the IJV in the neck, and then you place a ruler on the sternum, and then another ruler on the IJV, and then you both rulers meet, and where they meet is exactly the measure for your JVP. Is that understood? Okay. So, what does it mean when your JVP is elevated? It's when JVP is elevated, it is sorry, the normal measure is from 6 centimeter to 10 centimeter. So anything over that is elevated, and when it's elevated, it can indicate right heart failure. So it's a sign, and it helps to, it tells the person that okay, there is it's a sign for right heart failure basically. For this patient, because his heart is dilated, so the pressure and volume in the right atrium is higher than that of the internal jugular vein. Hence, the blood flows back from the right atrium. Question 7, clubbing. So clubbing is changes in the area under and around the toenails and fingernails. Oh, I can say that. Okay, it occurs with some disorders. How do we check for clubbing? Basically, you tell the patient to hold their thumbs together, and then when you hold your thumbs together, there's like a diamond kind of space, diamond shaped. That kind of space can be seen, but when you ask the patient to hold their hands together, and if you can't see anything like that, then that is clubbing, and it occurs from low blood oxygen levels, and it also helps to it indicates a lot of diseases, such as I think one of them is tetralogy of Fallot, and so on. Yeah, that's all.
So, inhibition of the heart sound, S1. S1 is caused by the closing of atrioventricular valves, the, the tricuspid and the mitral valves, at the start of the systolic contraction of the ventricles, which like causes a lump sound. S2 is caused by the closing or the semilunar valves, the pulmonary and aortic valves, once the systolic contraction is complete. Now, S3 is heard roughly 0.1 seconds after the second heart sound, due to its rapid ventricular filling, causing the chordae tendineae to pull to their full length and like it strums like a guitar string. So this is normal in young, like 15 to 40 years old, healthy people because the heart functions so well that the ventricles easily allow rapid filling. But in older patients, it can indicate heart failure, as the ventricles and chordae are stiff and weak, so they reach their limit much faster than normal. Now, S4 is heard directly before S1. This is always abnormal and relatively rare to hear. It indicates a stiff or hypertrophic ventricle and is caused by turbulent flow from an atria contracting against a non-compliant ventricle. Now, crepitations. Crepitations are high-pitched and discontinuous crackling sounds. They sound like hair being rubbed together and are caused by excessive fluid, like secretions in the airways. It it is caused by either an exudate or transudate. Exudate is due to lung infection, such as pneumonia, while transudate, such as congestive heart failure. Now, this occurs when a small airway, like pops open during inspiration after collapsing due to loose secretions or lack of aeration during expiration. Atelectasis, atelectasis. And crepitations are much more common in inspiratory than in expiratory. So there are three different types of crepitations: fine, medium, and coarse. Hold on. Okay, the fine ones are typically late the fine ones are typically late inspiratory, and coarse are usually early inspiratory. Medium crackles, well, like other name for crepitations is crackles, are high pitched, very brief, and soft. It sounds like rolling a strand of hair between two fingers. Fine crackles could suggest an interstitial process, such as pulmonary fibrosis or congestive heart failure. Coarse crackles are louder, more low pitch, and longer lasting. They indicate excessive fluid on the lungs, which could be caused by aspiration, pulmonary edema from chronic heart disease, chronic bronchitis, or pneumonia. Okay, next is cardiac murmur. Cardiac murmur is the sound produced when the blood flowing through the heart is turbulent. The flow of blood is usually smooth and silent. However, abnormalities may cause turbulence. Causes of heart murmurs. The first one is blood flowing through an abnormal narrowing, such as aortic stenosis, mitral stenosis, or pulmonary stenosis. And then number two is blood flowing in the wrong direction through the heart and mixing with blood flowing in the normal direction. Mitral regurgitation, tricuspid regurgitation. Number three, an abnormal connection between two different parts of the heart. Blood, like atrial septal defect, patent ductus arteriosus. Blood flows across this abnormal connection, causing either mixing of blood going in different directions or too much blood flowing into another heart chamber. And lastly, blood flowing faster through the heart. For example, like functional murmurs in sepsis and thyrotoxicosis. Lastly, parasternal heaves is a pericardial impulse that may be felt, like it is palpitated in patients with cardiac or respiratory disease. Precordial impulses are visible or palpable pulsations of the chest wall which originate on the heart or the great vessels. This may be felt when the heel of the hand is rested just to the left of the sternum, with the fingers lifted slightly off the chest. Normally, no impulse or a slight inward impulse is felt. The heel of the hand is lifted off the chest with each systole. Palpations with the fingers over the pulmonary area may reveal the palpable tap of pulmonary valve closure, palpable P2, in cases of pulmonary hypertension. This usually occurs during right ventricular hypertrophy or very rarely severe left atrial enlargement. An example of this condition where parasternal heaves can be felt is cor pulmonale. Pulmonale? I don't know how to pronounce that one.
Yes, continue. Why are you stopping?
Question 9, doctor.
Sorry, can anyone please share your screen because my laptop screen is locked suddenly. Sorry.
Can I start question 9? Oh. Okay. Okay. So in the X-ray finding of our patient, we were able to see curly B lines. And so I'm just going to briefly read it because I'm not so familiar with it, and also everyone else. And then later we can see an example of the curly B lines that our patient had. Basically, to summarize it, it is infiltration of fluid in the lungs, okay? There are 3 different types: curly A lines, curly B lines, and curly C lines, and I'll only explain curly B lines today. So curly B lines are a sign seen on chest radiographs with interstitial pulmonary edema, okay? So if there is edema, which usually occurs with heart failure, you will find these, okay? They are thin linear pulmonary opacities caused by fluid or cellular infiltration into the interstitium of the lungs. Septal lines are also known as curly lines, as seen when the interlobular septa in the pulmonary interstitium becomes prominent. Okay, so this could be because of lymphatic engorgement. It could be because of edema of the connective tissue in the interlobular septa. All right, now they usually occur when the pulmonary capillary wedge pressure reaches 20 to 25, and basically the pulmonary capillary wedge pressure is actually I forgot to mention it here, but it's very similar to our end diastolic. It's usually quite similar to the pulmonary capillary wedge pressure. It should be 20 to 25 mmHg. Sorry, yes. No, these curly B lines occur when the pressure reaches 20 to 25 mmHg. In a healthy person, it should be only 4 to 12 mmHg. So clearly our patient has really elevated end diastolic pressure or also elevated pulmonary capillary wedge pressure. There's a picture here at the bottom, and you can clearly see the opaque infiltrations in curly B line on the right side. Now moving on, I also had to explain pleural effusion because it was a learning outcome, but I think learning issue, but I think it has already been explained, so I think we can skip that. And then echocardiogram. So echocardiogram is a new concept. It's basically not new concept in general for us.
Yeah, Sarah,
Yes.
we talk about pleural effusion as in the pathophysiology, but how do you see it in the X-ray?
Doctor, that wasn't in my question. My question was actually to differentiate what is pleural effusion.
Oh, okay. All right.
Yeah, okay. So
So
however, pleural effusion actually can
then
you
why
can
do you have curly B line just now? As
I'm not sure, like when we just divided the
aren't we not doing investigation now? Aren't we not doing like explaining the to interpret the findings on the chest X-ray? No?
yes, but he
Yeah.
only had 3B lines. He didn't have pleural effusion.
Okay, so this patient doesn't have pleural effusion? No?
No.
All right. Okay.
Okay, I
All
will
right.
add
Continue.
another picture. Maybe we can explain later. But basically, pleural effusion, it's water on the lungs, right? So we can sometimes see it as opaque at the bottom. If the person is standing up, you can see at the bottom of the lung, it's white, rather than it should be darker. And when they lay down, you can see the fluid sort of spread across the lung.
The patient has pleural effusion. That's why you have that as your learning issue, isn't it? You have curly B line. The patient has curly B enlargement of cardiac silhouette, presence of curly B lines with dilated pulmonary blood vessels and pleural effusions, isn't it?
Yes.
Yeah, so she has pleural effusion, and yeah, you have to explain how does it look like in an X-ray.
All right. Okay. Doctor, if I want to add the picture, it might
Yeah,
take.
go ahead.
Okay.
Doctor, I think for pleural effusion, we can in the X-ray we can see as in the lung like pool of fluid. Is it?
How do you see full of fluid? How you describe it? That is the thing that you need to find out, because now you are describing investigation, isn't it? You've talked about pleural effusion just now, you talk about pneumothorax, you talk about everything. Now you are going into X-ray findings of this patient. So you have curly B line. So you have explained that curly B line is because of you describe what the curly B line is, and it's because of interstitial fluid in the interstitial space of the lung. Okay, and then next you're explaining about pleural effusion. How do you see pleural effusion in the chest X-ray? You can see if it's, fluid is, you don't know whether it's fluid or not when you see in the X-ray, right? You can only see opacity. So how do you see pleural effusion in the lung, in the chest X-ray? Yes.
I think it would be like opaque, like a white area. Supposedly, the lungs should be like a dark color because the X-rays, the electrons could pass through it since it's air. But if it's fluid, then there will be like accumulation like of white area at the lungs.
Where? Which part of the lung? Did you all
At
find out? Did you all find out when you're supposed to interpret the chest X-ray, isn't it? Yes? No? Yeah.
The pleural space, right?
Mm-hmm.
Like at the bottom, like the lower part of the thorax.
Find out. Please find out. Okay, continue.
Okay. I think one of the girls will add the picture in the document. So I think next we can move on to echocardiogram. Can we, doctor?
Sure, sure.
Okay. So an echocardiogram, frequently known as echo, is a test that is going to use the ultrasound to show us the muscles and the valves in the heart. Okay, so the sound waves make moving pictures of your heart so the doctor can get a good look at its size and shape. Usually we use this to check the amount of blood, so ejection fraction, which I will explain now. We also use echocardiogram to look at the valve condition. Okay, so there are many types, actually more than four, but I think I'm gonna explain the two. So the first one is the transesophageal echocardium. Just keep in mind that sometimes for some patients, for example, the morbidly obese, we cannot really get a good echocardiogram echocardiogram image from their chest, so we have to put it through their esophagus, okay? Because when it goes through the esophagus, it doesn't have to pass the rays. They don't have to pass through bone or skin because the esophagus is really close to the heart, okay? So that's the main advantage of the transesophageal echocardiogram, okay? So basically anesthesia, and they put the probe inside and they are able to get images of your heart, okay? That's basically it. See, additionally, obesity and lung disease can interfere with standard echocardiography. Obese also, if there is a lung issue happening, sometimes we cannot get a proper image. The second one is the transthoracic echocardiogram. This is the most popular one, the more popular one, and it's when it's non-invasive, so it doesn't have to go in or anything. And then there's a gel applied on the chest, and then we use the handheld transducer to sort of scan your heart. Okay. Now I'm going to explain ejection fraction, which can be observed very well in the echocardiogram. Ejection fraction is the amount of blood that your ventricles are going to push out. Okay, so for example, when we talk about the left ventricle, when it contracts, how much blood is it pushing out? That is basically your ejection fraction. A normal left ventricular ejection fraction should be in the range of 55 to 70. A 65%, for example, means that 65% of the total amount of blood in the left ventricle is pumped out with each heartbeat. So basically what I just mentioned. Now, your ejection fraction can go up and down based on your heart condition and how well your treatment works. However, our patient, relating this back to our patient, he had a left ventricular ejection fraction of 35%, and 35% is indicative of heart failure. As I mentioned, it should be at least 50s. Now, our patient has dilated chambers. These were observed in the echogram. The chambers of the heart are dilated and large because the heart muscle is weakened and cannot pump effectively. All right, so just imagine, as the muscles just sort of stretching and kind of almost like a bit looser than it used to be. So the contraction is not as good.
Oh, ini yang dijumpa, yang dijumpa.
Okay. You can observe here, you have high functioning, which is greater than 70%, normal function, 55 to 70, low function, 40 to 55%. Possible heart failure is less than 40. Our patient has 35, so That's why he has heart failure. This is a picture of an echogram, I don't know, echo. And then you can see that it
Can
can
you show
see,
me the chest X-ray just now?
yes,
Up, up, up. Yeah, this one. Okay.
yeah, this one we just added pleural
Ah,
effusion.
yeah, this is pleural effusion. Okay. So you can see, I mean, it's not always look like this is like massive pleural effusion. Otherwise, you would see like you see the costophrenic angle. What is costophrenic angle? Is the angle at the bottom, at the edge of the lung. There's an angle, right? A sharp angle. So when there's pleural effusion, the angle is blunted. If you compare the left and right lung, okay, the left lung, the costophrenic angle is sharp. The right lung, I mean, on top of the fluid, you might not always see the fluid at that much, but you might, the early signs of pleural effusion, if it's like not a very severe pleural effusion, you can see the blunting of the costophrenic angle. Okay, continue.
Yes, doctor, I finished my part. Now question 11.
Are you presenting? I cannot hear you.
Okay. Hello, can you guys hear me? Because like my
Yes.
connection is unstable. So yeah, just tell me if you guys cannot hear me. So for next issue is about the heart failure. So the definition of heart failure is a chronic progressive condition which the heart muscle is unable to enough blood to meet the body's need for blood and oxygen. So next we move to the types of heart failure.
Okay, so I'll start with the types of heart failure. So there's two types. So there's left-sided heart failure, right-sided heart failure, and congestive heart failure. So for left-sided heart failure, the left side of the heart must work harder to pump the same amount of blood throughout the body. As there is heart failure, there would not be able to do so. And the most common cause of like left-sided heart failure are ischemic heart disease, systemic hypertension, mitral or aortic valve diseases, and primary diseases of myocardium. Can you move upwards a bit? Upwards, downwards. Anyone? Okay. So for left-sided heart failure, there's two types also called systolic failure and diastolic failure. The left ventricle loses its ability to contract normally. That's for systolic failure. So the heart cannot pump with enough force to push the blood into the circulation. So for the diastolic failure, due to this muscle becomes so stiff, it cannot be contract properly, and cannot be relaxed properly, and the heart cannot properly fill with blood during the resting period between each beat. So it becomes abnormal. Next, the right-sided heart failure is usually occur as a result of left-sided failure. So when the left ventricle fails, it increases the fluid pressure back to the pulmonary back to the pulmonary. So in effect, it's transferred back through the lungs, just as I said, and it will damage the heart's right side. And the right side will loses its pumping power and eventually will backflow the blood into the veins, and there will be swelling or leg edema. Next is congestive heart failure. It's the heart muscle doesn't pump blood as well as it should. Okay, Mashita.
Okay, next we move to the causes and pathophysiology. So, okay. First, we have in the causes we have coronary artery disease, high blood pressure, diabetes mellitus, heart attack, and also heart valve disease. So, coronary artery is the narrow of the coronary arteries in our heart, and usually caused by the atherosclerosis. So the pathophysiology is the atherosclerotic blood rupture in the vessel. So it will cause the coronary artery thrombosis. So and then the thrombus will transform the vessel and make it more narrow. Okay, so and then it will impair the blood flow. So it cause the imbalance between the myocardial oxygen supply and demand. So okay, and then we have high blood pressure. High is a condition in which our blood pressure is consistently higher. Okay, and then the pathophysiology where the high blood pressure can lead to heart failure is the left ventricle hypertrophy and diastolic dysfunction. This is as explained by Farah before because of the left-sided of in the diastolic failure, the left ventricle lose its ability to uh to pump the blood. So the hypertrophy is actually the compensate what happened in the heart. So it will increase the arterial pressure and also increase the wall tension of the left ventricles so that the hypertrophy occurs so that the blood can be pumped into the aorta normally. So and then stiffness of the left ventricle with diastolic dysfunctions, it will increase the left ventricle filling pressure and also lead to LVH and cause pulmonary congestions. So in this systolic dysfunction, the left ventricle mass will increase and it will cause the unbalance of the wall tension due to the increased pressure. So the contractile capacity of the left ventricle will decrease. So for diabetes mellitus, mostly because of the diabetes mellitus will lead to endothelial dysfunction. So high blood glucose level will lead to high insulin resistance, also hyperglycemia, hyperinsulinemia, and it will lead to endothelial dysfunctions. And then it will uh, cause coronary artery disease, and next lead to heart failure. So it also high blood glucose level also can lead to diabetic cardiomyopathy, and next will lead to heart failure. So the cardiomyopathy will be explained later in the next learning issue. So we have heart attack, where the death of the heart muscle due to loss of blood supply. This is the pathophysiology is similar to the coronary artery disease, but because it is due to impaired blood flow. So on partially occlusive thrombus in the coronary artery will lead to unstable angina and non-STEMI. And while thrombus completely obstruct the coronary artery will lead to STEMI. So it will cause heart failure. So lastly, we have heart valve disease. Okay, so we already learned that the heart valve, there are two types of heart valve disease, which is stenosis and regurgitation. So stenosis is the calcification or any valve scarring happen on the valve. It will cause the valve to fail to open completely and will lead to forward flow. And for regurgitation, the valve cannot close completely, so it will lead to regurgitation of blood. Okay.
Okay, next is the sign and symptoms. But Auni has already explained most of the signs and symptoms, so I'm just going to state it. So we just have shortness of breath, fatigue and weakness, edema, orthopnea, and PND. So I'll just go straight to neurohormonal changes. So neurohormonal changes, we have neuro changes and hormonal changes, which is first starting with, I'm sorry for the background noise. So starting with the neuro changes, which is the sympathetic nerves. Wait for a while, I'm sorry. Mm, okay, so the SNS is the quickest to act. So it will act on the heart as a node. So according to what has stated, activation of sympathetic nerves, and then the hormonal is the RAAS. So the increase of, it will lead to increased release of vasopressin and atrial natriuretic peptide. And this will conclude to arterial vasoconstriction, venous constriction, and increased blood volume and ventricular filling. And because of that, it will continue to have ventricular afterload and increased preload, which is going to have pulmonary or systemic congestion and edema. Okay, next.
Okay. I just want to add something for in the neurohormonal change. It is because of the overcomposition, overcomposition mechanism. So the heart will be overworked. Thus it lead to the heart failure. So okay, next we move to the management and treatment.
Okay, we will go straight to management and
So
treatment.
for the management in the medication, he was given the ACE inhibitors. So the mechanism of action of it. Can you just hear me? Oh, sekat-sekat. But can you guys hear me now? Is it clear? Okay, I'm sorry, like my connection is really bad. So now can you guys hear my voice clear or still
Yes.
sekat-sekat?
Yes, we can hear you. Okay, so right now we're going with management, treatment, and lifestyle modifications. So starting with medications, we will be after researching, we would give ACE inhibitors, which is lisinopril. The mechanism of action is it inhibits the process of the process of RAAS. Next is angiotensin 2 receptor blockers, which is losartan. This one is the mechanism of action is wait. I need to see. Sorry for the delay, guys. Okay, so for angiotensin 2 receptor blocker, which is losartan, the mechanism of action is to block the AT1 receptor so that it would have complete inhibition of angiotensin action compared to ACE inhibitors. So this is much more effective. Next, Rania, can you go down a bit? Okay, next is beta blockers. We would give metoprolol, which is a selective type. So this would decrease blood pressure. Hold on. This would decrease, this would eventually slow the heart rate, increase diastolic time, prevention of cardiac overcompensation. Okay, next is the aldosterone antagonist. This will inhibit the action of aldosterone in the collecting duct, where it will block the reabsorption of sodium, which would encourage water loss. Consequently, this leads to a decrease in blood pressure. Okay, next is diuretics. So diuretics is basically to reduce the blood volume. Okay, next we go on to the treatment. So the treatment available is, Rania, can you go back up? I'm sorry. So the treatment available is ICD, implantable cardioverter defibrillator, CRT, cardiac resynchronization therapy, LVAD, left ventricular assist device, and surgical procedures for heart failure, heart transplantation, PCI. Also, you can known as angioplasty, coronary artery bypass, and valve replacement. So the lifestyle modifications for to those who have heart failure would probably for smokers to quit smoking, to maintain or lose weight, to maintain if their weight is normal, and lose weight if they have like obese or probably going to obese. And you should track daily. You should track daily your fluid intake. Avoid or limit alcohol intake. Avoid or limit caffeine. Eating heart healthy diet. Being physically active. You should manage your stress. Keep track blood pressure or symptoms, and you should select appropriate clothing. Meaning like wearing baggy clothes is better than wearing tight clothes because it doesn't make your blood pressure spike. Okay, that's all. Thank you. Next question 12. So who's doing question 12? Can you start explaining your part?
Balkis, are you there? Balkis or Ifa?
Did you all compile this learning issue in one file?
Yes, doctor.
Okay. So why is it every time that you have to reproject?
I don't
Because you only need one person to project the thing, right?
yeah.
And the others present. Yeah.
I was projecting, but I want to see if Ifa and Balkis is in the meeting.
Oh, okay. Why shouldn't they be in the meeting? I thought you said everybody is here.
Because they're not
Yes,
responding.
I think everyone is in the meeting, but it's their part to present, but I don't know where they are right now.
I was
Okay,
just
then
But they
what
are
is the
in the
point?
meeting.
Then what is the point of? So can we just do a spot check now? Who is here and who is not here? What's the point of wasting
Doctor,
like
do you
2 hours?
Doctor, do you want me to
Otherwise,
like send the
I will
attendance
call
now?
you. Yeah, please send the attendance now.
Okay. All right.
But doctor, we already signed. Like I already signed, and I think someone else signed also in the group.
Okay, so you're telling me that they might already sign it?
No, I'm saying I signed already, so my time would not correlate with others. But I'm here.
Okay, all right.
Me too, doctor.
Doctor,
I
me too. I
accidentally
also
signed
signed it
early.
earlier.
So those who is not here, have they signed? I don't see the point of this presentation or um, this PBL when you are presenting to I don't know who. You understand what I mean? Because this is not for me. It's supposed to be your discussion. If I were to run away, it's okay. But you all cannot run away. Even so, I'm listening to all of you.
Hello. Okay,
Yes.
I tried to call Balkis, but she's not answer.
No, so we consider Balkis is not here. Okay, who else is not here? You don't have to call her to present. She is not here. She is not
Okay.
here. Okay.
Okay. So I will present for her part.
Yes, please. Just
Okay.
discuss. No need to present. So
Okay.
Balkis is not here, right?
Mm. Okay. So the dilated cardiomyopathy. So first, definition for cardiomyopathy is a disease that the heart muscle that make the heart muscle cannot pump the blood to the rest of your body, and it can lead to the heart failure. While for the dilated cardiomyopathy is a disease of heart muscle that is characterized by ventricular chamber enlargement and the contractile dysfunction. So for um, the causes remains unexplained.
Sorry. I can explain the causes and pathophysiology. Hello,
Yes,
can you
please.
hear me?
Okay.
Yes. You
Okay, so
can you explain it in your own words rather than reading? Everybody can read, then you can go back and read. If you were
alright,
to
okay.
read macam baca berita, what for?
Yeah,
Just explain.
cardiopathy has been explained what is it. So now I'm going to continue the causes. So in many cases, it is unexplained, but nowadays, with the advancement, most of the idiopathic cases can be identified. What are the contributing factors that usually cause acquired cardiomyopathy? One is genetics, alcohol, peripartum myocarditis, hemochromatosis, chronic anemia, and doxorubicin and sarcoidosis. Okay. Now I'm going to explain to you the pathophysiology. So about dilated cardiomyopathy, based on the word cardiomyopathy, you can see cardio means heart, myo means muscle, pathy means disease. So from here you can see that this is related to the heart muscle itself. In this case, this is characterized by ventricular enlargement or dilation of ventricle and systolic dysfunction, which has problem with the ejection fraction, and it has greater left ventricular cavity size with little or no wall hypertrophy, which means that the cavity of the ventricle is large, but is not balanced with the size or the thickness of muscle itself, the ventricle muscles. So what this can cause is this progressive dilation will cause mitral and tricuspid regurgitation, which can diminish the cardiac output and increase end systolic volume. So as we know that the dilation, okay, firstly, why the dilation happens? When the cardiac output is low because of the dysfunction of the muscle, the heart will try to compensate by increasing the size of the cavity by dilating. So when the heart dilates, it will increase the cardiac output, and then it tries to dilate again until it cannot dilate anymore, and then it will show the symptoms of um, heart failure. And then we know lah this person have dilated cardiomyopathy. So so yeah, that's it. So when we have dysfunction in the muscles of the muscle of the ventricle, and then we have regurgitation and heart failure. So basically that's a cardiomyopathy. Okay.
Okay, so next for the symptoms. 25% of our patients have atypical chest pain, and other symptoms is depend on which ventricle is affected. So for the left ventricle that is affected, it will cause dyspnea and fatigue. And for the right ventricular failure, it will cause peripheral edema and and neck, neck vein distension. Okay, for the risk factor, it is most commonly occurs in men, which is age 20 to 50, but it can also occur in women. Other risk factors is damage to the heart muscle, family history that have the dilated cardiomyopathy, inflammation of the heart muscle, and the neuromuscular disorders. Okay, so for the complications, the dilated cardiomyopathy will cause heart failure because of the poor, poor blood flow. It can also cause heart valve regurgitation because of the enlargement of the left ventricle will cause the backward flow of the blood, and then the heart can pump effectively. It also can cause fluid build up, which is edema, arrhythmia, sudden cardiac arrest, and the blood clots. So for the prevention is by maintaining the healthy lifestyle, which is don't smoke, don't drink alcohol, don't use cocaine or illegal drugs, eat healthy diet, especially low salt diet, maintaining healthy weight, follow exercise and get enough of sleep and rest. So that's all.
Doctor, I think we're done for all of our parts.
Sorry, is it all?
Yeah. Because
Okay.
like we put the learning issues kan the hari tu ada macam 20 plus, so we compiled it.
Jadi berapa? Oh, saya ingat tak habis lagi. Alright.
Dah.
Okay. Alright. Okay. Um, concept map. Okay, can you all submit, because we're running out of time? Can you submit to me the concept map? Uh, you all know how to do concept map, right?
Yes, we did it
Yes.
last week. Last PBL.
So boleh tak submit kat saya? Can you all submit email to me the concept map, but you have to work in groups. Yeah, because you don't have time. Is there any other questions? Is there any other learning issue that you all still confused?
Doctor, I just want to ask, like Prof. Latif said that digoxin is no longer relevant. So in this patient, like we ended up giving him digoxin. So how is that?
Do we?
Like hari tu Prof. Latif said digoxin is like not the best option to give
Okay.
to
Why?
patient because it may causes more damage to the heart, I think.
How?
Uh, like he didn't explain it, but I was just like curious, like if it's okay to give this patient digoxin.
Well, I think it's still in use. You have to actually ask Dr. Azli. I'm not quite sure. Or maybe you can ask Dr. Latif again, Prof. Latif again. Okay.
Okay, doc.
Yeah, but the purpose of this, because you're in year 2, we are not concentrating so much on management. You know what to give and what, you know, but it's more on the action of it. What are the action of digoxin? Something like that. You concentrate more on that. But what are the side effect of digoxin?
From what I remember, it inhibits your NAK pump. So when there's an increase intracellular sodium, so then there's no exchange of calcium and sodium. So then it will lessen your like contraction. But I don't know like the side effect of it. I just know like the mechanism of action of digoxin.
Hmm? Is
It's
is that
it's to reduce the contraction of the heart.
is that the side effect, or it's the use of it?
Is the use of it. So I
It's
think
the
maybe
use of it.
if it's prolonged, maybe then the heart would be damaged because like to I don't know. I don't know.
It is more of it can use arrhythmias or dysrhythmias. Okay, it will interfere with the heart rhythm, so it is actually quite dangerous. Okay, so
Okay.
it is only given if your diuretics and ACE inhibitors doesn't work, you know.
So
So
it's
you
like
are
the
correct.
last.
Yeah, so you are correct. Yeah, if you can give diuretics and ACE inhibitor and it works, you actually don't no need to give digoxin because of the side effects. Dysrhythmias and diarrhea, GIT symptoms, and you tend to have um, high in toxicity. Because you have learned therapeutic index, right, in general pharmacology.
Yes.
So it has a very narrow therapeutic index. So you really have to monitor the level. So you can easily get toxicity from digoxin. Okay, so you are correct. It is not like the first choice drugs to give.
Okay, doctor.
All right. Okay. Any other thing?
Oh, and the concept map, should it be sent individually or
No,
as
it's a
group?
group work.
Oh, okay.
All right. Okay. All right. I know it's difficult this time because it is online. Okay, if I have a choice of doing it face to face, I would prefer the PBL session to be more of a discussion rather than presentation, because as you know, no one wants to listen to presentation. It should be more of a discussion. So usually I don't really also follow the learning issues very strictly, because sometimes when you have covered that topic earlier, so you might want to skip some of the learning issues. So if you have done some learning issue and you think that there are also some other points that is relevant to that, so you can straight away discuss that. You don't have to wait for your turn for learning issue, then only you want to talk about certain, you understand what I mean, the flow. Okay, all right, so can we adjourn now? Thank you very much. If there's no questions, all right,
Thank you, Doctor.
thank you. Okay,
Bye,
Thank you,
Doctor.
Doctor.
Okay.
bye.
Okay, kita nak bincang konsep map ke? Eh,
Semua dah left dah.
Cakap, okay. So, lepas tu apa kita nak buat ni?
Kau balik.
Sekejap.
Ni share screen kan?
Kejap
Okay. Siapa ada contoh yang Dr. Atika punya tu?
Gambar tu ke?
Oh, ada dekat M14. Sarangan Faidah tak ada kan? Boleh cakap bahasa Melayu kan?
Tak ada. Dekat sini.
Bukan, boleh mic ni ke kan?
Cardiomyopathy kan?
Maksudnya kena tulis idiopathic dilated cardiomyopathy. Lepas tu congestive heart failure. Macam tu je lah kan? Sebab yang heart failure dia ni sebab cardiomyopathy tu kan. Tapi cardiomyopathy dia ni tak ada causes, so tak tahu macam mana.
Sekejap, yang ni kita nak start dengan macam mana kalau Dr. Atika hari tu dia start dengan trigger ke apa?
Hari tu Dr. Atika tu dia start dengan benda tu lah. Dia start macam atherosclerotic plaque. Lepas tu obstruction, lepas tu restrict blood flow, lepas tu dia start dengan tengah-tengah tu dulu. Lepas tu baru dia tambah semua tepi-tepi tu.
So kita kena buat patofisio untuk cardiomyopathy.
Tapi cardiomyopathy kita tak ada causes kan?
Ya tu.
So ada idiopathic kan? So kita punya arrow ada dua je lah kan? Untuk tengah-tengah tu kan?
Tapi myopathy tu secondary tu apa nama?
Dia heart failure tu secondary to idiopathic.
Oh, so heart failure lah tengah.
So heart failure
Cardiac myopathy kat tengah lah. Primary cause.
Primary cause cardiomyopathy tu. Lepas tu arrow ke congestive heart kan?
Cause kan?
Itu cause.
Lepas tu
Lepas tu boleh macam dia apa tu dia heart failure yang menyebabkan decrease effort tolerance tu.
decrease effort tolerance. Heart failure. So boleh buat arrow yang dekat atas kot. Boleh lah, macam tu pun boleh kot.
So kita rasa daripada decrease effort tolerance tu macam baru bersambung besar sikit.
Lepas tu yang atas tu pakai colour lain kan? Lepas tu
boleh balik.
apa lagi?
Dekat dalam ni tak payah tulis macam ni ke, macam kan start kan yang cardiomyopathy kan. Lepas tu low cardiac output bukan macam tu, tak payah. Terus heart failure ke terus macam tu kan. Yang hari tu kan
yang Dr. Atika buat kan atherosclerotic plaque, terus obstruction of coronary artery, terus MI macam tu kan. Kalau nak buat pun boleh kot. Jadikan tengah-tengah tu je lah kan.
Maybe daripada macam mana how dilated cardiomyopathy ni boleh menyebabkan
Lead heart failure. Boleh juga.
lead heart failure.
Lepas tu kiranya yang decrease effort tolerance tu nanti jadi macam extra arrows je, bukan main.
Ada semua. Kita apa tadi?
Okay.
Macam mana? Cardiomyopathy macam mana boleh jadi heart failure?
Okay. Semua faham yang the true meaning dilated cardiomyopathy tu. Dia
cardiomyopathy tu muscle dysfunction, maksudnya dia tak boleh contract kuat enough to bagi apa normal blood flow. So start dengan cardiomyopathy lah. So
pasal dilated tu apa maksud dia? Apa yang dilate sebenarnya? Heart tu lah kan?
Ventricle tu. Ventricle tu, cavity.
Sebab compensate, try untuk compensate yang dia lemah tu kan?
Heart
tu. Start dengan sekejap. Jadi kena start dengan idiopathic dulu.
Dilated cardiomyopathy tu bila you punya ventricle tu enlarged.
Yelah.
Contraction jadi
ventricle enlarged dulu baru decrease contraction of heart. Balik.
Bukan sebab apa tu kita sebab the myocyte
dia punya
Itulah hypertrophy jadi kurang contract.
Tapi ni dia cakap heart ability to pump blood decrease sebab left ventricle enlarge and weaken.
okay. So
So ventricle enlarge tu yang sebab idiopathic tu, sebab kita tak tahu kenapa ventricle tu enlarge. Faham tak?
Okay, faham.
I rasa ni cantiknya tulisan. So low contraction of heart, low cardiac output, heart failure.
So next. Apa tu? Ni kena buat daripada idiopathic tu error ke enlarge and weaken ventricle.
Lepas tu I rasa lepas cardiac output tu baru tulis idiopathic tu tak?
Kan?
Sebab all of that is idiopathic kan sebenarnya.
Idiopathic tu unknown cause is mula-mula sekali lah, bukan?
Idiopathic tu yang
Ida first lah idiopathic sebab macam unknown causes lead to enlargement.
Aku tidak macam mana pula left ventricle dia boleh enlarge dengan weaken kan?
Macam tu boleh tak? Ataupun idiopathic tu satu line kan dengan heart failure tu biar tapi kotak tu still faham tak? Turunkan sikit.
Faham? Turunkan.
Buat konsep map pun susah.
Ya tu, banyak kali kena padam.
Kita betul ke tak ada exam ni? Kan tak study lah.
Baca tak Ruben cakap? Tiba-tiba malam Khamis dia bagi tahu.
Mampus.
Oh, dia tak cakap yang ada online ke tak? Aku ingatkan online.
Tak, dia just cakap online classes, dia tak cakap exam. Tapi dia tak confirmkan juga. Batal.
Cuma apa tu yang John begini tu?
Kalau kita buka.
Okay. Yang John cakap yang Dr. Azli cakap forward face to face.
Tapi tu bukan official.
Tu lah.
Ni boleh tak idiopathic dilated tu warna hitam juga?
Boleh.
Lepas ni kita kena buat ni tu pre-PBL. Sebab macam lost gila tadi.
Serius.
Lepas tu sekarang baru simptom-simptom lah kan?
Betul?
Lepas tu kita pakai pen colour lain.
Kalau apa?
Colour apa-apa lah. Lepas tu kita letak dekat bawah heart failure tu macam pulmonary edema dengan pulmonary effusion. Nak kena terangkan ke? Kena terangkan kan? Tulis ni dah dulu tak? Heart failure tu increase venous pressure, lepas tu increase hydrostatic pressure, lepas tu baru pulmonary edema dengan pulmonary effusion.
Betul?
And of course. And of course. Apa ni? This postpone.
Postpone.
Yay! Oh yeah.
Suka.
Dia tu.
Nanti dia letak 1 hari dengan respiratory mucus tu.
Okey, patut fisio.
Lucu kita tak nak exam.
Nanti kan dia cakap dia bagi study break kan?
Oh, ya ke?
Dr. Azli tu cakap later we'll give you study break. Tapi mesti 1 hari. Tak ada nak study break sangat pun.
Macam tak biasa CSMS. University of Sarijaya.
Tulis heart failure and then increase venous pressure. Increase hydrostatic. Oh no.
Lambatnya file ni. iPad kita lagi laju. Okay, lepas tu?
Increase venous pressure, increase hydrostatic pressure, increase interstitial fluid. Lepas tu kembangkan jadi edema, orthopnea, dyspnea. Tak pulmonary. Lepas increase interstitial fluid tu buat edema, pulmonary effusion dengan pulmonary edema dengan pleural effusion. Lepas tu dekat bawah pleural effusion dengan pulmonary edema tu baru buat apa? Yang orthopnea, dyspnea, apa semua tu kot. Yang semua
Pulmonary effusion dengan edema.
Dengan edema,
Sama je. Alia nak solat ke? Asal? Postpone. Exam postpone.
Suka betul exam postpone.
Berapa orang dah? Oh, balik kampung lah. Itulah dia tadi buka pintu nak cakap boleh balik je.
Maybe for pulmonary edema and pulmonary effusion, you can put like heart murmurs to indicate that the person has pulmonary effusion or pulmonary edema.
Can also. Lepas tu tambah satu lagi, edema yang edema. You know like the leg edema tu. Tambah satu lagi branch.
Oh, pitting leg edema tu
Leg edema je lah.
Ya,
Lepas tu dekat pulmonary. Jolie, the murmurs is because of pulmonary edema and pleural effusion ke?
Yeah.
Oh, pleural effusion bukan pulmonary effusion.
Wait, no. Heart murmurs is supposed to be for if backflow. Sorry, crepitation is indicating pulmonary edema and pulmonary
So nak kena buat arrow keluar lah kan?
For pulmonary edema and pleural effusion, it's supposed to be crepitations, not heart murmurs. Heart murmurs is supposed to be backflow or like turbulent flow of the blood.
Because the heart failure lah kan?
Yeah.
Ni satu lagi, dia pleural effusion bukan pulmonary effusion. Lepas tu pulmonary edema dengan pleural effusion tu jadikan macam mana cakap arrow yang crepitation, lepas tu dyspnea, orthopnea, apa lagi? Tu je kan? Dyspnea, orthopnea je kan?
Tu je. Bawah simptom. Tapi macam ni ke yang korang fikir?
Betul tu. Boleh tak sebelum venous pressure tu jatuh bawahkan sikit, tambah backflow of blood. So kat situ kita boleh buat heart murmur tu nanti.
Heart murmur macam ni?
Heart murmur, lepas tu yang S3 S3 punya sound tu.
Oh, jap.
Guys, kan hari tu kan dia macam diagnosed with right ventricular failure kan. Lepas tu macam mana boleh tukar jadi idiopathic dilated cardiomyopathy?
Macam mana? Ulang balik.
Kat hari tu PBL kan dikata patient is diagnosed with right heart ventricular failure, right ventricular failure benda tu kan.
Tak ada heart failure lah tu. Heart failure lah. Ni memang dekat dalam progress tulis idiopathic dilated cardiomyopathy ni.
Oh, tak lah Dr. Dani cakap hari tu. Lepas tu,
Masa tu doktor cakap dengan congestive left dengan right. Yang tu bawah heart failure. Kita ada 3 jenis. Congestive, left dengan right ventricular failure. Macam tu kan?
lepas tu idiopathic dilated cardiomyopathy ni bawah apa?
Yang ni macam
Primary cause lah macam tu lah kan.
dia cause.
Kenapa heart failure tu berlaku kan? Sebab heart failure kan banyak punca macam tu.
So yang ni congestive ke right ke left?
Everything kan, everything heart failure. Congestive rasanya. So dia tak cakap, dia tak specified kan.
Ada yang dekat heart murmur tu S3. Kita boleh dengan S3.
Okay.
Ya, okay. So apa lagi yang kita boleh buat?
Yang presence of curly bee line semua tu.
Oh, X-ray yang tu.
Kita kena masuk ke gambar.
Tak ya kan?
Tak ya.
Just terangkan je. Pulmonary yang curly bee line tu pun sebab pulmonary edema juga.
Ni tarik keluar. Pulmonary
Ataupun
edema.
jadikan macam ni macam satu lagi warna lain pula untuk pulmonary edema dengan pleural effusion punya terangan. Macam X-ray punya findings. Ya Allah, susahnya.
Apa tadi? Curly bee line.
Curly bee lines dengan apa lagi tu je lah kan. Dengan ni dekat apa? Dekat salah tak tahulah yang dilated pulmonary blood vessels tu I tak tahu nak letak mana.
Dilated pulmonary blood vessel.
Dekat increased pressure tu ke?
Kat blood flow.
Blood flow.
Effusion tak ada letak kat sini.
Apa?
Boleh juga kat pleural effusion tu tulis apa yang tadi tu? Opaque apa? Lah yang gambar tadi tu.
Maksudnya kat sini.
Opaque.
Oh ni. Apa
Opaque
nama dia?
lower border of thorax bukan? Tak?
Blunting of postophrenic angle.
I just realized one more thing. Can you put heart sound S3 to indicate heart failure?
Dah buat tadi dekat backflow of blood tu.
Oh, okay. Thanks.
Okay. Apa lagi? Ni satu lagi. Kita tak tuliskan decrease effect tolerance tadi kan?
Tak boleh lagi.
Kalau tambah je satu arrow kat atas heart failure tu boleh?
Hitam
Tak. Hitam sebab hitam macam mint.
Buat warna apa-apa lah, warna lain kot.
Lepas tu mitral regurgitation ni kita nak letak mana Dekat backflow juga.
Rasanya?
Tapi bawah macam ni. Tepi venous pressure.
Sebab mitral regurgitation tu sebenarnya sebab heart failure tu kan?
Backflow. Mitral and tricuspid regurgitation tu backflow.
Letaklah bawah backflow tu warna Warna biru kot, boleh kot warna biru tu. Tapi kita punya echocardiogram global chambers dilation tau.
Tricuspid.
Semua dilated.
Apa sorry Rania?
Yang kan echocardiogram kita, dia punya result global chambers dilation. Maksudnya semua chambers dilated. So kalau yang dekat dalam kotak yang idiopathic dilated cardiomyopathy tu, buang LV. Jadikan macam chambers enlarged and weakened je. Sebab semua kan, sebab macam mana? Semua satu. Lepas tu ambil warna orange, letak dekat enlarged and weakened tu. So ada echocardiogram global chambers dilation.
Lepas tu kita boleh letak yang cardiac apa ni shell
Silhouette tu yang enlarged tu kan.
Yang tu. Enlargement of cardiac silhouette.
Yang global chambers tu tulis lah echo, lepas tu X-ray yang cardiac silhouette enlarged tu.
Ni echo.
Yang ni echo, tu echo.
Yang ni X-ray yang cardiac.
Aku ni pakai fountain pen aku ni untuk cantik. Tulisan I sumpah buruk gila. Dia cardiac apa?
Cardiac ni. Cardiac.
Silhouette.
Macam tu.
Dah lah kan tu je kan. Ni ubat. Yang furosemide kita semua tu nak kurangkan simptom
Apa dah? Sama-sama.
Kalau yang furosemide, ACE inhibitor, spironolactone, digoxin, semua tu letak dekat heart failure tak boleh?
Sekejap, korang boleh dengar saya okey ke? Crap.
Tak okey sangat.
Sekejap
Actually,
Yes.
like where should we put the like furosemide, ACE inhibitor? Because like purposely those are the things like macam tu kurangkan contraction, right? ACE inhibitors for like hypertension and all kan. So like where should we put the arrow?
Yang venous pressure tu kita boleh sambung lagi buat ni ke JVP elevated.
Boleh? Warna apa?
Maybe then you can put the ACE block, was it ACE blockers or was it beta blockers?
Kita rasa tak ada biru
ACE
sebab dekat dengan
inhibitor.
biru ni. So dia macam
ACE inhibitor, and digoxin. Beta blocker also. kita letak dekat heart failure tu tak boleh?
Boleh je. Aku rasa kalau buat kotak kat tepi tu pun untuk macam medication pun boleh tak?
Tapi doktor itu dia buat macam arrow.
Saya rasa macam buat dekat apa, contohnya digoxin untuk apa, so kita
Ah.
letak dekat simptom tu.
Letakkan dekat heart failure tu.
First drug kita nak letak drug apa ni?
Ada furosemide, ACE inhibitor, spironolactone, beta blocker dengan digoxin.
Mana
Letak je kat heart failure tu tak boleh ke? Arrow dia ke arah heart failure tu.
Yelah, apa beta blocker tu nak letak dekat heart lah. Beta blocker. Beta receptor tu dekat heart.
So semua tu tengok doktor kan buat macam mana ada punya ubat antiplatelet coagulant, thrombolysis, dia macam fokuskan kat mana. So kita buat
ACE inhibitor ni untuk ni kan, kidney kan? Ke apa? Kidney kan?
Dekat bukanlah kat kidney,
dia
dekat dalam blood. Tapi renin tu produced by kidney.
Tapi dia punya major function dia adalah untuk kurangkan blood volume tu kan, function dia lah.
So kita boleh cari dekat kurangkan blood volume.
Tapi tak ada dekat kita punya map ni, tak ada. Kita rasa letak je kat heart failure tak boleh? Sebab
Try letak semua dulu dekat heart failure, lepas tu kita cari tempat yang sesuai untuk dimasukkan. So kita ada ACE inhibitor.
ACE inhibitor, furosemide.
Furosemide buat apa lah?
Furosemide pun diuretic.
Oh, dia block apa? Block something ke dia?
Dia macam biasalah dia prevent your body to absorb salt. So bila you punya body tak absorb salt, dia tak akan absorb water. So blood volume kurang. So tak adalah banyak sangat blood yang nak dipump macam tu lah.
Dia ganggu aldosteron ke macam mana?
Tak, dia inhibit NAKCL pump.
NAKCL pump.
Supaya you punya sodium, potasium dengan chloride tak masuk balik dalam blood vessel. So dia nak kita punya body buang lah benda-benda tu.
Oh, sodium potassium pump lah.
Tapi nama dia sodium potassium chloride pump.
Oh, yelah sebab sekali dengan kalsium chloride.
Bracket.
Diuretic, furosemide dengan satu lagi, apa nama dia? Spironolactone. Diuretic ada dua.
Yang tu bawa diuretic juga
Check. Bawa diuretic juga.
Spironolactone.
Spironolactone. LACTONE. Lepas tu ada beta blockers.
Aldosteron kan? Aldosteron antagonist. Beta blocker.
Dengan digoxin tu.
Digoxin. So yang angiotensin tu receptor blocker. Yang ni diorang tulis dekat yang kita punya PBL.
Yang hari tu kan? Boleh check.
Aldosteron antagonist, beta blocker dah buat. Dah. Angiotensin 2 receptor blocker.
Aku punya opinion lah kan untuk kita buat macam ni kan. Ni nampak macam ubat ni menyebabkan heart failure. Tak rasa ke?
Macam mana Dr. Tika buat untuk arrow untuk ubat, rasanya macam doktor letak satu simbol.
Tapi doktor hari tu dia letak sebab different drug tu untuk different causes, faham tak? Kan? Kita punya sebab kita tak ada like macam itulah tak tahu macam nak sebab dia tak ada hypertension kan. Dia just nak sebab hypertension tu datang nanti kan, tak silap I. Doktor Prof Latif ni kelas hari tu kan dia cakap
Beta
heart failure tak
beta
hebat. Dia just
beta
nak kurangkan simptom
aku
je.
rasa tu lah boleh letak kat cardiac output low cardiac output beta blocker.
Tapi kalau beta blocker low cardiac output tak sesuai sebab nanti dia akan menyebabkan lagi kurang cardiac output tu.
Lagi pun macam beta blocker kan dekat.
Yelah kita kan nak increase kan. Increase cardiac output letak beta blocker lah.
Kalau letak beta blocker lagi kurang lah cardiac output.
Sekejap. Beta blocker.
Sebab beta blocker kan nak block contraction.
Reduce
Dia
your
negative
blood pressure.
inotropic. Dia reduce blood pressure.
Ni reduce cardiac output juga
Ya. Tapi sebab hari tu doktor Prof Latif cakap yang benda-benda ni semua adalah untuk macam mana cakap dia nak
tak nak bagi tu sebab dia orang macam apa compensatory
sebab nanti bila cardiac output ni macam mana bila heart failure ni your body kan nak compensate balik kan. So dia akan naikkan nanti dia akan releasekan RAS apa benda semua tu. So this is where you punya ubat ni function sebab dia nak kurangkan simptom. Sebab heart failure kan dah tak boleh betulkan kan. Dia just boleh kurangkan simptom je.
Faham.
Kalau
maybe kita boleh buat macam Balkis cakap tu yang kita letak under treatment.
Boleh je lah macam tu.
Ke nak buat yang macam Dr. Atikah juga cari satu-satu tapi
ataupun kalau tapi macam tak muat dah kan kalau kita buat macam heart failure tu satu lagi warna kita buat macam compensatory mechanism, faham tak? Lepas tu kita cakap lah apa-apa. Lepas tu treatment dia apa-apa macam tu.
Boleh.
Tapi takut tak muat.
Ya. Sampai dah.
Tak tahu hari kita kat mana.
Kena buka modul Prof Latif. Sekejap kita buka.
Page 56 tu.
Boleh basically dia ni boleh letak arrow tepi tarik tu, lepas tu macam atas arrow tu tulis ke sini. Compensatory
mechanism. Cakap lah macam RAS, lepas tu ada sympathetic,
boleh tak boleh tak kat sini, lepas tu kat bawah tu listkan apa dia.
Yang atas tu boleh padamkan yang warna pink tu. So kalau nak naikkan atas sikit pun boleh kot sebab takut tak muat tu.
Cari lagi. Apa tu? Mekanisme dia antara dia increase SV.
Kalau tulis macam sympathetic semua tu tak boleh je? Activate sympathetic, activate RAS, activate aldosterone.
Boleh lah. Boleh lah buat macam tu je lah.
Ke benda-benda tu kita letak bawah CO?
I think dia buat bawah compensatory pun okey ke macam.
Yelah, compensatory tu kita letak sebelah heart failure ke nak letak bawah CO? Dua-dua okey je sebenarnya kan?
Faham.
Kan sebab dia nak compensate CO punya problem.
Yang ni bawa daripada CO bawa compensatory. Sebab body kita nak compensate daripada low cardiac output.
Betul tak? Ke I salah faham?
Betul. Faham. Mana boleh sambung dengan kereta?
Kalau kita tiru apa tu Prof Latif punya, bukan tiru,
Modul.
macam ambil konsep tu lah. Maksudnya kan dia dah buat kat situ heart failure, lepas tu pergi menyebabkan reduce CO tu ada digoxin, lepas tu
Memang cuma kat reduce CO tu kita buat tu je lah. Macam mestilah doktor nak tahu kat mana digoxin tu function kan. So kita tulis je lah yang compensatory mechanism dia apa. Lepas tu kita tak payahlah terangkan pun compensatory mechanism tu kot. Just letak je macam
digoxin.
Q&A lah for presentation. A video presentation. Lepas tu dia cakap each video presentation will be followed by Q&A.
dia nak tanya-tanya lah Kalau dia nak tanya-tanya macam apa.
Digoxin ni bagi kuatkan jantung kan? Inotropic drug. Kurangkan apa?
Kurangkan contraction.
I think hari tu
Inotropik ni bukan maksudnya kuatkan kuatkan jantung. Maksudnya kuatkan contractility.
Tapi je
saya rasa masa doktor cakap hari tu digoxin ni dia buatkan heart tu beat harder. Lepas tu dia ni
dia increase contraction, dia increase strength on contraction kan.
Dia macam dia bukan untuk heart failure. Doktor cakap, Prof cakap dia macam more to atrial fibrillation.
Arrhythmia semua kan.
Bukan tak payah ni, dia punya direction heart failure tu bagi inotropic drug digoxin supaya boleh overcome reduce CO. Muka surat 56 tu, tengok tak? Kan dia tulis heart failure, lepas tu leads to reduce cardiac output tu kan? Lepas tu dia letak digoxin tu untuk kurangkan reduce CO, maksudnya tinggikan CO lah kan? Tapi
maybe kot sebab heart nak bagi, sebab jantung beat harder kan, so increase
contraction. Tapi doktor cakap macam orang tak galakkan sangat guna kan sebab dia banyak.
Dia tu sebab ni kan narrow therapeutic index.
Ya.
Tapi Dr. Nani kata, Prof Nani kata boleh je pakai lagi.
Dia kata boleh pakai tapi it's not the first option dia kata. If you punya ACE inhibitor semua tu dah tak function baru boleh.
Kita nak letak ke tak dekat dalam kita punya ni?
Kena letak sebab dekat dalam progress ada.
Lepas tu nak letak kat mana? Dekat CO tu lah kan?
Yelah sebab kena tulis dulu compensatory mechanism tu dekat bawah tu kena letak compensatory mechanism dulu.
Tapi kan low CO tu bukan compensatory mechanism.
Tak, bawah CO tu then your body will do compensatory mechanism. Kan sebab macam cakap kan nanti your body akan give compensatory mechanism.
Iya, apa kan sekarang ni low CO, lepas tu dia compensate apa? Body compensate apa?
Dia mati. Betul dia cakap.
Apa?
Sekejap.
Dia apa soalan baki lagi sekali?
Tak, kan kita nak tulis compensatory mechanism, lepas tu kita nak letak drug supaya boleh kurangkan compensatory mechanism effect kan maksudnya? Tak, sekarang ni ubat digoxin tu untuk low CO, bukannya untuk kita kurangkan effect compensatory mechanism.
Nanti letak sila digoxin tu dekat arrow CO tu tak boleh?
Untuk low CO.
Betul lah. Letak dekat low CO tu, tapi bukan digoxin bukan untuk
bukan letak dekat compensatory mechanism tu lah.
So
sebab dalam table Prof tak guna pun digoxin untuk treatment.
Ni kita nanti letak dekat atas CO tu je lah. Maksudnya lain punya macam cakap.
Kan dekat dalam kita punya kita punya map tu kan dah ada low CO tu kan.
Yelah,
So,
tambah situ je lah.
letak kat situ je.
Macam yang Dr. Atika tu buat je.
Okay.
So first buat yang compensatory mechanism tu sikit. So ubat lain-lain semua function dia untuk kat situ, kat compensatory mechanism tu.
Betul-betul.
Lepas tu buat arrow compensatory mechanism.
Compensatory mechanism tu warna lain, lepas tu nanti drugs tu pun warna lain lagi satu. Lepas tu tulis je lah macam activation sympathetic. Lepas tu
Ini bukan drugs kan?
Buat
lepas
macam
tu
point
RAAS.
buat kalau guna
purple je.
Yang parasympathetic tu tak payah kot. Buat yang kita activate je lah sebab nak compensate kan.
Sympathetic.
Lepas tu renin angiotensin RAAS drugs.
Kalau sebelah compensatory mechanism tu buat kurungan tulis activation boleh tak? So you tak payah tulis setiap bullet tu activation.
Letak activation, lepas tu titik bertiga. Dia tarik sympathetic ni bawah sikit.
Sebab yang suppression kita tak payah buat kot, kita buat yang activation je. RAS, lepas tu aldosterone,
Lepas tu adrenaline.
noradrenaline. Tu je lah kot yang brain tu tak payah lah.
Jarang yang tu kan.
Doktor cakap jarang.
Diorang tutup kedai RM20 sebalang.
Angiotensin tu?
Sana? RAAS. Okay.
Yelah, bawah RAS aldosterone.
Adrenaline dengan noradrenaline. Adrenaline tu bukan lain lain punya branch I mean like lain punya bullet, bukan
Kita buat sekali. Yang
sekali
level angiotensin tu.
Boleh betul lah tu kot.
Sana tu. Angiotensin 1, angiotensin 2. Angiotensin 2 ni dia akan trigger adrenaline ke?
Tak tahu.
Apa dia?
Cuba tengok yang Auni tunjuk tu. Angiotensin 2 tu memang akan trigger adrenaline ke?
Sekejap I check
Oh. Angiotensin.
Macam ya juga baca ni. Tapi kalau nak buat sama ke lain ke tak apa kot.
Abla buat je lah.
Bawah tak kisah, tak kisah.
Biar je lah. Okay, lepas tu
kita pergi dekat drug, ambil colour lain. First letak arrow ke arah low CO2 tu dulu, digoxin.
Tambah, arrow tambah.
Lepas tu furosemide tu dekat
Directly dekat volume. Aldosterone
dia inhibit NA pump tu sebenarnya. NA, tapi tak tahu nak letak macam mana tu.
Sekejap. Slide.
Sodium potassium pump tu ambil sodium kan dalam darah.
Dia NaCl pump. Benda tu dia akan ambil balik daripada air kencing masuk ke dalam blood vessel.
Yelah, increase blood pressure.
Dia nak reducekan blood pressure.
Nak reduce kan. So tak ada reabsorption.
Tak ada reabsorption.
Buang salt lah. Buang Na. So reduce blood pressure. Blood pressure.
Maybe ni kot bawah daripada CO ni kan decrease cardiac output akan buat decrease BP kan. So kita macam boleh tarik arrow.
Aku rasa dekat ni bawah compensatory mechanism tu letak ni increase in blood pressure. Lepas tu boleh tulis
instead of tulis sympathetic dengan RAS tu kita buat macam positive inotropic. Lepas tu kita buat increase blood pressure. Lepas tu dengan tu increase sodium and water retention. Lepas tu kita boleh potong-potong kat situ.
Betul. So first increase blood pressure.
Increase ni tak, increase ni tulis positive inotropic dengan conotropic. Lepas tu increase sodium and water retention. Lepas tu boleh sebab
Guys, I'm gonna excuse myself, okay? Because my iPad battery is already 1%. I need to charge it.
Okay, thank you for today.
Thank you guys for doing all of this.
It's okay. Bye Jolie.
Bye
Bye,
bye.
Jolie. Okay.
And then ni apa? Increase sodium and water retention. Lepas tu arrowkan ke bawah lagi satu, increasekan blood pressure. Macam tu je lah conclusionkan dia. Untuk semua tu.
Sambung ni.
Macam concludekan je lah.
Jadi increase blood pressure.
Arrow besar je pun tak apa kot. Kan? So increase blood pressure. Lepas tu baru kita buat furosemide tu dekat NaH2O retention. ACE inhibitor pun dekat situ.
Negatif.
Negatif. Negatif ni buat.
Spironolactone pun dekat situ.
Negatif sebab
Dia
inhibit.
inhibit.
Okay.
ACE inhibitor dengan spironolactone tu.
Tu kat mana?
Dekat sama tempat, dekat retention tu.
ACE inhibitor. Betul. Dekat.
Kan? Dia
betul,
untuk
betul.
tu kan?
Betul.
Beta blocker kat mana? Heart
Beta blocker dekat Iono ke Chrono, tak tahu.
Tapi
Sekejap.
boleh dua-dua kan? Lebih kurang.
Patut buat contractility dulu.
Iono apa? Chrono apa?
Iono contractility. Chrono.
Tak, dia increase contractility. Ni. Tengoklah tu.
Nak buat macam ni? Boleh tak? Buat macam ni dulu.
Contractility dulu.
Increase.
So nanti arrow-nya dekat contractility tu je kan?
Chronotropic.
Chronotropic heart rate. Inotropic contractility. Tapi boleh je increasekan chrono.
Increase.
Wait, cardiac remodeling ni apa?
Hari tu John tanya tapi tak ingat.
Remodeling.
Yang page sebelah tu kan?
Tapi dia tak baik.
Cakap changing inside mass geometry function of heart after injury.
Sebab dia
maksudnya
susah nak
effect dia lah.
Dia remodel, dia jadi elongate. Macam tu.
So macam effect heart failure tu lah kan?
Dia macam kira macam try untuk adapt lah dengan
Try to adapt tapi sebenarnya dia lagi menerukkan.
Dia tukar structure lah sebab nak adapt dekat situation tu. Oh, satu lagi dekat retention tu ni apa spironolactone.
spironolactone.
Yang ni semua minus ke?
Semua minus.
Kita nak ni kan, tak nak bagi
Sebab
dia
kita tak nak retention tu.
kan nak tak kat sebelah. Yang boleh je mana ni.
Beta blocker chronotropic sebab reduce heartbeat.
Tapi letak under contactility tu pun okey dah kot.
Boleh juga dua-dua.
Dah siap.
Dah siap. Ni je obat yang dia bagi kan? Tu je.
Okey. Dah. Habis
Dah.
InsyaAllah. Tu je lah.
Siapa nak bagi? Ika. Hantar kat Ika si Ika email kot.
Ini boleh bagi warna merah tak apa. Okay. Okay, thank you everyone.
Thank you Auni. Thank you
Have a
Nani.
good
Thank you
weekend.
Bakis. Yay, tak ada exam.
Nak punya soal dia apa? Okay, bye.
Bye. Ya, Ma.
Apa? Apa?